Hello everyone. Let me present you my progress in my project revolving around different topics in radiology. My name is Teodóra Filipov. I am a PhD student at the at the Department of Interventional Radiology at Semmelweis University. My vision is to lower patient discomfort by offering less invasive diagnostic tools and minimally invasive treatment options. And my mission is to research these novel interventions and techniques and stay up to date in the field. As an overview of my two projects, there are different topics. One of them is transplantation, and the other one is an interventional topic. So the first one is the ultrasound-based elastography in the evaluation of kidney allograft function. As we know, kidney transplantation is the most effective treatment for end-stage renal disease, but chronic or acute allograft injury occurs in 25% of patients within the first year. The preferred method for discovering these changes is biopsy, but it is an invasive method which has its own risks. There is a new promising method, elastography, to assess kidney fibrosis and dysfunction minimally non-invasively. So we wanted to see if there is correlation between elastography findings and other dysfunction parameters in a kidney transplanted population. We conducted a systematic search in October, and out of more than 6,000 studies, we were able to include 11 into our meta-analysis. Regarding our results, we asked for subgroup analysis according to the correlation calculation type they use. Our first outcome is the correlation of elastography values and biopsy results. This was the main reason we conducted our meta-analysis. Here we can see quite a high heterogeneity. The study by Egfr is a French study, a pediatric study, and they only found low fibrosis cases. And all of the other studies are also very heterogeneous in the regard of age, gender, and kidney function. But overall, we can see a moderate correlation between elastography and biopsy results, which is promising. Next, we assessed the correlation between elastography values and resistivity index, arterial resistivity index. Resistive index is a calculated flow parameter that assesses the stiffness of arteries, and it is assessed by Doppler ultrasound. What we can see here is, again, a very high heterogeneity, because some articles included stable patients, some included patients with suspected pathology, and there was also one study that included really young transplants. What we can see here is a very variable and heterogeneous result, and this suggests that maybe these two parameters are not dependent on each other, so maybe we can use them together to assess kidney dysfunction. Our last two outcomes, we assessed the correlation of elastography with different laboratory parameters. First, creatinine. Blood creatinine level is a very important measure in assessing kidney dysfunction. As kidney function declines, creatinine increases. Here, again, the two studies included patients with suspected pathology. Some included patients who were stable. And here also, we didn't get any statistically significant results. And the correlation we see is very low. The next outcome, or last outcome, was the correlation of elastography and EGFR. Here we can see that the articles that found a very high, EGFR is also a very important measure in kidney function. It actually decreases as kidney function declines, so this is the reason we have negative correlations. And by the articles that have the highest negative correlation, we found that the population was predominantly male and slightly younger. So maybe that is something to consider, but again, our results are very weak and not statistically significant, so we have to see what we'll do here. The strengths of our meta-analysis is that it is the first of its kind assessing correlation of elastography compared to several kidney dysfunction parameters. We assessed several outcomes, but unfortunately we could only include a limited number of studies because a calculated correlation coefficient wasn't included in most studies, and our study population is very heterogeneous, and the assessment of heterogeneity couldn't be appropriately carried out because the variables for subgroup analysis were not present in studies. As a conclusion, though, from our results, we can say that there is a moderate positive correlation between elastography and biopsy results. But the degree of kidney dysfunction and fibrosis influences these results and the correlation assessment majorly. The elastography can be used safely in the transplanted population because these kidneys are more superficially located. And further research to assess sensitivity and specificity of this method is necessary to be able to implement it into the clinical practice. My second project is a protocol for an interventional clinical trial, the percutaneous ultrasound-guided cryoablation for fibroadenomas. Fibroadenomas account for 12% of all palpable breast masses, and traditionally these lesions are treated surgically. 500,000 women undergo surgery per year for these lesions, and mostly they occur in a really young age, but any woman premenopausally can have fibroadenomas, and because these are these can be recurring lesions, a minimally invasive approach is rising and starting to get more, better than surgery. Cryoablation is fast, painless, and can be delivered in a doctor's office and has minimal recovery times. So we wanted to see how effective cryoablation is in the management of fibroadenomas, because a less invasive approach would lower patient discomfort and risks of surgery. We are going to include women above the age of 14 who have core biopsy-proven fibroadenomas that are in safe distance from the skin, and breast tumors and prior breast lesions that are suspicious. We are going to exclude these patients. We are going to use for the intervention the ProSense device by IceCure Medical. which works with a cryoprobe inserted into the lesion, and this probe is cooled by liquid nitrogen that forms an ice ball around the lesion, and the edges of the ice ball is minus 40 degrees Celsius, which causes changes in osmosis and cell membrane damage, which will result in cell death and cell lysis on the long term. Our follow-up times are going to be 1 month, 6 months, and 12 months. Okay, yeah, we are going to assess several outcomes, primarily the degree of volume reduction. And yes, we want to submit these projects at the end of this spring, and let me end my presentation with the quote from William Osler: "The good physician treats the disease, the great physician treats the patient who has the disease." Thank you.
Thank you very much, Dorka.
I wanted to ask you, in what cases would you do any kind of intervention? Because as far as I know, with fibroadenomas, they pretty much never become malignant, and even observation by the patient herself might be enough.
Yes, thank you. They never become malignant, that is true, but they can grow in a really, really fast, and they can get quite big. So it causes huge, big discomforts for patients, and it can, so they can hurt, and it's actually, yes, basically treatment is there for the patients, but also because many of these patients have recurring fibroadenomas, and if they always resect them surgically, it can have a cosmetic outcome that is not wanted by patients. So that's why we are testing this intervention.
Can we go back to your creatinine slide? That's the second one. That's just an example. So you said in this one and in the next one too, I mean, there are big differences actually in the outcome in different studies. And if we go to the next one, in this one too, actually, one is standing out a lot. And then you just said that there is a high level of heterogeneity. But there must be some other things too, I mean when having this data. And this is about digging for the truth. So do you see anything what is different between these studies which actually could cause these big differences among different studies?
Well, all of these studies are pretty much conducted in the same way. But as I said, some study, there is a really high difference in what kind of patients these studies included. And also, there is a big difference in the calculations of correlation, and it depends highly on the amount of patients and also kidney function. So we just got these plots recently, so we have to find some way to give an explanation for these results.